can it reverse the fact that 1 in 9 people are actually on a waiting list for hospital treatment in England?
Well, Trevor, let's start with the impact on patients. And I think it's really important. We talk a lot about the statistics here, but we just need to remember that there are far too many people who are waiting too long for treatment as a result of the disruption caused by COVID. And we just need to remember that this means that there are 6 million people who are in pain. At the worst end of things, we know that potentially these conditions can worsen and potentially turn into permanent problems. So every trust leader is completely aware of the need to get through these backlogs as quickly as they possibly can. We've worked very hard on this plan. It is stretching. It is very stretching. I mean, the Institute for Fiscal Studies this week described the headline ambition of getting to around 130% of the levels of activity in this area by 24-25 compared to what we were doing pre-COVID. So a 30% increase in levels of activity. They described that as certainly ambitious. So we've set ourselves a very stretching target, and we know that we're going to need to really do a number of different things to ensure that target is delivered. The bit that's the complexity here, Trevor, and I think a lot of the media coverage this week I found slightly frustrating, is the problem the NHS has got. If you look at the core waiting list issue about how big the waiting list is, we simply don't know how many extra patients who didn't come forward during COVID are going to come onto the waiting list. So we could be actually delivering that 130% headline target, which would be amazing, fantastic, and yet the waiting list would still be going up. So we just need to be careful about saying we're just going to judge NHS performance solely by how big the waiting list is, because we know it is likely to grow because all of those people who didn't come forward during COVID are going to come forward.
Well, I want to come to that in a second, but if we may, can we just deal with one, if you like, public service point here? One of the flagship aspects of this new plan is My Planned Care, which is described as an online service informing patients about waiting times and how to prepare for treatment. And the idea is that this will reduce cancellations. Can you just quickly explain how it actually is going to work?
Yeah, so what we're basically saying is that in order for patients to, and there's I think, quite an interesting concept here called wait well, they need to know 2 or 3 things. The first is they need to know when are they likely to get treated, and that will prevent, hopefully, large numbers of communications going backwards and forwards about exactly when the treatment will happen. Then the second bit would be we know that about 1/3 of cancellations are due to people who've got conditions such as diabetes, high blood pressure, where those conditions haven't perhaps been managed as well as they might be in the run-up to an operation. So we get to the operation day and then they effectively find that we have to cancel. So part of this is about providing and supporting appropriate information to enable people with those conditions to be in the state of health that we need them to be at the point when the operation happens. And I think all of us in the NHS know, Trevor, that we are behind not just the private sector, but other public services in terms of our use of digital. Part of that has been the lack of investment that we've been able to make. But this is a very good example of where we do need to ensure that we support our patients to actually use our services in a 21st century way. So this is another way in which we can increase and improve our use of digital.
Well, OK, thank you for that. Look, there are a number of new targets and we still have to see how they're going to be operated. But one of the questions that I think this plan raises is that there are still things that the health services have to achieve before they get to these new targets. So, for example, in August last year, there was a record high number of patients urgently referred by their GPs, waiting for over 2 months for cancer treatment. We know that cancer patients often don't have 2 months to spare, and we're not even meeting the diagnosis targets yet. I mean, shouldn't we be thinking about getting that stuff done before we introduce some of these new things?
Yes, and that's absolutely what we're going to be doing. We've made a very clear commitment that we will prioritise the most urgent cases, of which, as you quite correctly identify, the most urgent cancer cases are key. And that's why we've set ourselves a target that 75% of GP referrals for cancer diagnosis will actually be seen within 28 days, because we know that's a really, really important task. One of the issues we've got here, Trevor, is that if you're a trust leader and you've got a very large number of people who are waiting, training, there is quite a sophisticated but incredibly important operation to do in terms of clinical prioritization. And when you talk to trust leaders, what they'll tell you is that they spend a huge amount of time working with frontline clinicians, working with computer systems patient records to really identify in what order we should be bringing patients in. And of course, we will focus on those who are, have the greatest clinical priority, those who are most in urgent need. But this is in the context of, and let's be really clear about this, nobody in the NHS would want to see a waiting list of this size. And what's happened is we've had two problems. The first is we've had insufficient capacity in the NHS after a decade of the longest and deepest financial squeeze in NHS history. So the waiting lists were already growing before we went into COVID. And then what we've had is this huge disruption over the COVID period. So these waiting lists are they're by far the biggest we've seen for a very, very long time.
We've spoken about this issue of capacity before, and to the layperson, that is a problem about numbers of staff. You're, I think, 93,000 people short overall, nearly 40,000 nurses short. What can possibly be done about that, other than perhaps some really determined and intentional recruitment from other countries?
Well, Trevor, you put your finger on it really, really well. And we're just literally in the process of finalising the health and care bill, where there was a whole bunch of us who were saying to the government, you have to have a proper long-term workforce plan. And if it takes 3 years to train a nurse and 13 years to train a consultant, you have a very significant lead time here. So how can you expect the NHS to have the right level of workforce that it needs if it's not got a proper workforce plan in place? And there's been an amendment that was debated in the Lords that was originally proposed by Jeremy Hunt in the Commons, which it's incredibly important that we pass. So the answer, Trevor, is that there is good news down the track in that we are now seeing very higher levels of people entering training. But if I'm really honest, we've got this very difficult period over the next 2 or 3 years where we know we won't have enough staff. And you're absolutely right. There will be a significant premium on recruiting people from overseas. But that's not a comfortable place to be. It also isn't particularly helpful for the nations from which we're taking those staff. So we've got to have a proper workforce plan. And if I'm honest, I'm incredibly frustrated about the fact that the government will not sign up to the idea of a proper long-term workforce plan, which is what we have in every other sector of our economy and what we have in every other national health system. I can't understand why the government won't sign up to what seems to me to be blindingly obvious.